Hello and welcome to Inside Exercise. I'm Emeritus Professor Glenn McConell from Melbourne in Australia. The brief of Inside Exercise is to bring to you the absolute who's who of exercise research in regards to exercise physiology, exercise metabolism, and exercise and health. The brief there is to bring rigor to the field. So, go into depth, but also make it accessible to the masses. Okay, so try and bring it down a little bit as well. Today we've got Michael Riddell, who's a professor from York University in Canada. He is the absolute who expert in type 1 diabetes and exercise. He actually has type 1 diabetes himself, as does his son. So that brings a different perspective to it. Obviously, he gets very into it and has done an amazing amount of work in the area. We go through a lot of things together. So we discuss, obviously, what is type 1 diabetes, what happens to metabolism during exercise in people with type 1 diabetes, the importance of trying to avoid hypoglycemia after exercise, and indeed how that is one of the things that makes some people with type 1 diabetes not want to exercise. So, they've got the usual situation of, trying to motivate people to exercise, but they've also got that concern about hypoglycemia. So we go into that. But importantly, we talk about how critical exercise is for people with type 1 diabetes. So naturally, it's important for all of us, but we're actually seeing a situation now in people with type 1 diabetes where instead of the previous situation where they tended to be, underweight, if anything, because they're inactive on average, they have, diet and not sufficient exercise, poor diets, they tend to be overweight. So they're getting a situation now where they can have type 1 diabetes, but also superimposed on that insulin resistance. So more like the type 2 diabetes syndrome. We also talk about glucose, continuous glucose monitoring, insulin pumps. We talk a bit about professional athletes that are type 1 diabetic. So, it is very much possible if you have good glucose control, etc., to do very well with exercise. And we talk about the pathology of type 1 diabetes, etc. So I think you'll really enjoy this. So stay around. Okay. All right. Hi, Michael. How are you today?
Oh, Glenn, I'm great. How are you doing? Good to see you.
I'm great. Yeah. I could see a nice background there, bikes and things. So actually,
I'm showing off a little bit. I do have a nice road bike that I love to get on, and I did bring one of my spin bikes from the lab because it was getting in the way. So I brought that home, and now my daughter uses it, and from time to time I'll use it too.
So what do you do for exercise? Just cycling?
I don't think I do anything exceptionally well, but I do love to bike. I did a lot of mountain biking when I was younger. And going through university, we were mountain biking almost every day. I do some road biking, and I played a lot of squash and tennis, and
a little bit
of running.
You look fit.
Yeah. Oh, thanks, Glenn. Not half as fit as you, I don't think.
Oh, well, maybe we'll talk about that later. I do a bit of riding. I used to be a runner, but I'm pretty ordinary nowadays. Okay, so we're going to be talking about type 1 diabetes and exercise, and you are the man on that. So how about I just thought we'd start with what is diabetes and what is, type 1 versus type 2. People don't really know that.
Yeah, absolutely. Diabetes is primarily a defect in blood sugar metabolism, although it goes beyond just blood sugar control. It goes on to lipids and protein metabolism. But type 1 diabetes is the form of diabetes where the body doesn't make its own insulin, and insulin is the hormone that regulates our blood sugar, among other things. Type 2 diabetes is patients often still produce some insulin, but their body's more insulin resistant. So they might need medications to help them get the insulin working more effectively, or maybe a bit of weight loss or lifestyle changes so that the insulin becomes more effective. But type 1, you're born with this disease that might be part genetic, part environmental, where you just lose the ability to produce insulin. Yeah. So that requires insulin therapy.
Yeah, so as you said, that you tend to think of type 1 more in kids. It's not always the case. It's not always that it comes on in childhood, of course. And then you tend to think of type 2 as more later in life, overweight or whatever. So just to clarify that. So can't help saying, of course, that you yourself have type 1 diabetes and your son. So what's
Yeah.
that like to live with that? I mean, really.
Well, for me, it was a diagnosis that came as a teenager when I was fairly active, but losing weight because I had developed diabetes over the span of probably 3 months or so, weight loss, fatigue, blurred vision, frequent urination. These are the symptoms of type 1. But when I was diagnosed and treated, I felt pretty good. I could get back to sports. I could eat a really fairly normal diet. But I did have problems with exercise. I had problems with low blood sugar with exercise and sometimes high blood sugars. And so that was kind of the impetus for me to study metabolism after this diagnosis,
Right.
and to study really sports medicine. And then things kind of changed though when my son developed type 1, because I started to worry a bit more about my son's health, and what would his future look like, maybe without a cure for type 1 in the next 20 or 30 years. I don't think there's going to be one. So I became a bit more worried, as a lot of parents are when they have a kid diagnosed with type 1, because you can take too much insulin and have a low blood sugar reaction, lose consciousness, and some people have even died from from insulin shock or severe hypoglycemia. So that's when I started to worry a bit. But that's just the life of a parent. You're always worried about your kids for some reason or another, anyway.
Yeah. Well, it's hard enough.
But
it's hard enough for a parent bringing up a kid, but it's hard enough for a kid, growing up.
yeah,
With all the puberty and all the stuff and the awkwardness and whatever else. And then, I don't know, having
right.
to sneak off and take insulin shots, or, it depends
Yeah,
now if they've got
and it's a little, it's a little bit more visible now, isn't it? Because some kids wear pumps or glucose monitors, so they're testing their glucose. So other people around them might ask them, like, what are they doing? Why are they wearing that thing? What's wrong with them? So when I was diagnosed, it was a little bit more invisible, and that may be good or bad for people, because I think it's good to share that you have diabetes. But for him, it's quite obvious he has diabetes. He wears a pump. You can see the pump, the tubing. So it's different, but I think better, because you don't want to hide this disease, because you might need some help from time to time with your blood sugar control.
That's a good point. I just want to touch on that. Yeah. So with the pump, because I tend to still think of a lot of people running around doing finger pricks and having to inject insulin, etc. Why don't you just give us a bit of an idea, like, how, I guess it depends on whether you're in rich countries or also how much the government helps with payments and whatever. What sort of proportion of people are still, injecting insulin versus having a pump and having continuous, what we haven't touched on is continuous glucose monitoring, which I know you're massively into, of course, personally, but also with your research.
Yeah.
What's the balance like that in different countries? And is it almost an assumption in Canada that people have the full gear now? Or?
Well, in Canada, we have coverage for insulin pumps, and some provinces have coverage for the continuous glucose monitors. They're expensive. But even though we have coverage in Canada, and most of the US has coverage, the uptake of insulin pumps is about 50% right now. But it looks like in the pediatric populations, in larger, more progressive cities, it might be as high as 70, 80%. So I think the kids are taking on the technology maybe better than some of the people who've been living with type 1 since childhood, but now they're in their 50s or 60s. They may not be as keen on trying a pump. Although my mother-in-law also has type 1. She's 74 and she wears an insulin pump. We got her to switch 4 years ago, because I think it does give more physiologic insulin replacement than taking needles.
So I guess once they make the switch, there's no going back. Is that right? Like
Yes.
at first, or
yeah, most people do not go back. Most people use phrases like freedom, which is hard to believe because you're attached to something, but they say their life has a lot more freedom around what they can eat, how they can do physical activity. But some people don't like it. And it may be 20% of the people who try it just say, no, I can't handle the itching, the tubing, changing the infusion sets. I'd rather just take the needle and then not worry about it. So I wouldn't say there's universal acceptance, but more people stick with it than not after they try it.
Okay. And with the continuous glucose monitoring, so here, maybe just explain very quickly what that is. But
yeah,
I guess, is it pretty much like everyone that's doing continuous glucose monitoring has an insulin pump, or is there some, that have,
That's a great question. You'd think that everybody who had an insulin pump that can infuse the insulin minute by minute, they would also have a glucose sensor that can measure their glucose minute by minute. But that's not the case. Some people just have pumps, some people just have CGMs, and some have both. And I don't know why that is. It could be access or cost. It could be just wearing another device. But for me, I would never wear an insulin pump without a CGM, because now my CGM, my continuous glucose monitor, communicates my glucose values to my pump so that it can either increase the delivery rate or drop the delivery rate of insulin. And that's physiologic. It's biofeedback now in an artificial pancreas. So that's where, that's how I manage my diabetes. My son manages my diabetes. Most people who are academics or engineers or athletes tend to, unless they're doing a sport where they just can't have a pump on, like maybe a basketball player or something like that.
Actually, just that point there about it's probably been 2 or 3 years ago. I spoke to an endocrinologist that I was doing research with, and he said quite a lot of people are worried about that concept of the machines talking to each other and they don't trust them. And even sometimes some doctors don't want to prescribe these to their patients because they worry. Is that still the case? Is that?
I think it. Yeah, Glenn, I think it might be. I think that there's a bit of a fear of having something take over your management, which
like
is not easy. It's not easy. And if that machine gets it wrong, it can be life-threatening. So, but overall, the safety data on these devices, because they're FDA approved or EU approved or health care approved, they are quite safe. There have been very few adverse events associated with insulin pumps, but they still can cause problems. Absolutely. So there is that fear. Some people like to drive a car manual stick shift, and some people love a new electric car that does everything, backup cameras, and it depends on your personality a bit, I guess.
All right. So how about we just think a little bit about metabolism during exercise? So people with obviously people that don't have diabetes, they start exercise. If we're thinking about glucose, there's a lot going on, but the liver releases glucose, the muscles are taking up glucose. The glucose doesn't necessarily even change much for the first hour or so, depending on the intensity. If you're doing prolonged exercise, your glucose is pretty much matched by the glucose output from the liver, the glucose uptake by the muscle, right? And then it starts to drop. So if we think first of all about prolonged exercise, is that the similar thing? Or I guess it depends again on how much insulin they've got on board. So if if they didn't have a pump and they just had a shot of insulin, their glucose could drop a lot, right? We'll just talk about prolonged submaximal first, and then we'll talk about other. That's right. So,
sure. Well, that's what I was so fascinated by, this physiology that seemed so automatic for people who didn't have diabetes. And I was reading all the literature that was published at the time by people like David Wasserman or Heinrich Galbo, or my PhD or my postdoc supervisor, Mladen Vranek. The body just beautifully balances glucose. It keeps it really quite tight during prolonged exercise because the liver's dumping about the same rate that the muscle's taking it up. And I couldn't figure out why I was taking insulin. Why can't I mimic this? And I just couldn't, because most of the time when I did aerobic exercise, it would go down. Other forms of exercise, it would go up. So I started to learn that in diabetes, the insulin in circulation will really predict how much your blood sugar will change. As you said, we often are exercising after we've taken some insulin. And so the insulin in the body is quite high. What I also learned, and I think this is quite fascinating because it's very difficult to normalize, is that when you go for an exercise bout or when you eat a meal, you're secreting insulin into the portal vein. And that portal vein feeds the liver. It talks to the liver first. So the liver gets a heads up when you eat. It gets a heads up when you exercise. But I inject my insulin or infuse my insulin into my leg. It's the wrong place for my insulin to go. So I can't really mimic your physiology when I eat or when I exercise. So my control will never be as good as yours, Glenn, if we go for a bike ride. I just have to do my best to try to emulate what your body's doing by changing my insulin delivery patterns or relying on carbohydrate feeding, much more so than the carbohydrate feeding that you were publishing when I was reading your work in the 90s, like how much carbohydrate you need for aerobic exercise. I was learning that that wasn't quite enough for people with diabetes who are exercising with high insulin levels. Yeah, so your work informed my work greatly in the 1990s.
No, great. Okay. Yeah, so that's an interesting one I was going to actually bring up later, but just while we're at it now, sometimes you think about, well, if you've got everything matched, if so you've got enough insulin on board to take up the glucose at rest and during exercise, etc., then you should be about the same as a person that doesn't have diabetes. But you're obviously saying that's different, and you would actually need a higher peripheral level, I guess, to get the same sort of effects on the liver, etc. Is that
exactly?
Right?
You are 100% correct. And some of the research that is progressing in this field is looking at two things. One, could we deliver insulin into the portal circulation, or at least the interperitoneal cavity? Because then you could get that insulin to the liver first, and you wouldn't have to infuse such high levels in the periphery to communicate with the liver. The other thing that people are doing is trying to change the insulin molecule so that the liver preferentially clears it. And you can do that with some molecules that make a liver-targeted insulin, which I think is quite fascinating. So it is something that is still very experimental. And the promise is there that maybe one day we can mimic your physiology a little bit better by having it, communicate with the liver first for food, but also for exercise, because we want that portal circulation to drop as soon as we begin exercise, because that helps the liver dump glucose. And that's really hard to do in type 1 diabetes, really hard.
Okay. So I was just trying to think through this. So if your insulin's actually higher so then you're going to have higher glucose uptake, but you're going to have less inhibition on the liver, is that right? Or sorry, so the liver's going to be inhibiting.
The liver is being inhibited by hyperinsulinemia in the exercise state. So high insulin after a meal, maybe 3-4 times higher than your insulin levels after a meal, because of the way I deliver it. That's putting the brakes on glucose production by the liver. And it's also facilitating glucose disposal into exercising muscle, non-exercising muscle, maybe even fat cells, because you have hyperinsulinemia, relatively speaking.
Okay, so you're really going to have to rely more than me, for example, on carbohydrate ingestion if it's prolonged exercise.
Yeah, in fact,
you're not getting your liver glucose output.
Correct. It looks like in recent papers we've published and consensus documents, if exercise lasts longer than 30 minutes, you're going to likely need some carbohydrate. Whereas, for you can get away with 60, 90 minutes and you don't have to. You don't have to. You may derive some performance benefit at 90, but for us, it's keeping us alive. Like, we have to consume that carbohydrate, or where our blood sugar becomes so low, we die.
Wow. Yeah. So, because I've noticed the whole way along, we've done carbohydrate ingestion studies, but also fluid ingestion studies. And I noticed the first hour, even with fluid, if you drink, we did a study like no fluid versus fluid equal to your weight losses versus half, whatever. Your heart rate, your body temperature, no difference the first hour. And then it started to separate. And obviously, if you drank fluid, your heart rate would be lower and whatever. Same with carbohydrate. If you drank carbohydrate or not, for the first hour, it doesn't drop. So this is in someone that doesn't have diabetes. And then it drops. But you're shifting everything earlier, so to 30 minutes, for example.
Oh, much earlier. I've been on hockey rinks and sports camps with a kid who has diabetes, stepped on the hockey rink 30 minutes after his lunch, and he was in an insulin coma within 30 minutes of playing hockey.
Holy crap.
Loss of consciousness, and you had to use rescue glucagon by injection to bring him back to life. So this is a fear that many patients with type 1 diabetes have. Like, they don't even want to exercise, they're too afraid. And it's about, one of the things that I work on now as a parent with a child with type 1 is like how to break down that fear so that it's rational and manageable by using different technologies and insulin dosing and
Wow.
carbohydrate feeding
It's
strategies.
complicated. It's well, as you know, it's complicated. It's probably
Yeah.
more complicated for me because I've been thinking about it for years and years. But okay, yeah, because okay, again, I said it's early, hard enough being a kid growing up without having diabetes, or who
Yeah.
knows, kids have other conditions as well. But then it's hard enough to get people to exercise, as we know.
It is.
But then you've got to try and get people with type 1 diabetes to exercise, and they've got their worries about the hypos and things. So maybe just a
That's
little
right.
bit
A fear of low blood sugar is one of the biggest barriers to getting people with type 1 active. And we know that people with type 1 who are active, they live longer, they have fewer complications, they need less total daily insulin dose, and there's all these psychological benefits too. So we want them to exercise, but we just want them to do it safely. That's all.
That's the thing as well, I guess, because you tend to think, okay, why should a person with type 1 diabetes exercise? And you think about the glucose, the insulin, but they've got all the same reasons the rest of us have.
Yeah.
Reductions in heart disease, and they're going to get an increase in insulin sensitivity too, aren't they?
Which, right. Exactly. So
which
we
is
think
a double-edged sword, obviously.
Yeah, right. That is a double-edged sword, but I think in the long run, it's quite good to be insulin sensitive if you have type 1, because what that means is that if you have a plate of pasta or a bowl of cereal, you don't need to inject as much insulin. And so maybe you're not exercising with such relative hyperinsulinemia. Maybe it's just safer in the long run. And studies are suggesting that people who don't use as much insulin, they actually have a little less hypoglycemia, which is good. It's the one thing that they fear. But they need enough insulin that they don't have hyperglycemia, because we know that hyperglycemia in type 1 diabetes leads to kidney failure, retinopathy, premature heart disease, and all these other things. So it is a balancing beam for sure.
Yeah, it sure is. Look, I think you just cut out a little bit there. You were just saying it's a balancing. Yeah, it just cut out a little bit there. Oh, now I've lost my thread of thought.
Sorry about that.
Yeah, so the balancing act there. What I was going to say, we started talking about obviously focusing on exercise. So we talked about prolonged exercise, how the sugar tends to stay the same in people with diabetes and non-diabetes for the first 30 to 60 minutes, and then it drops. But an interesting thing, which when you first hear about this sort of does your head in a little bit, is the fact that if you do high intensity exercise, so whether you've got diabetes or not, you can actually have an increase in glucose. So why don't you just talk about that a little bit? So adrenaline, causing the liver to pump out high levels of glucose even when you stop.
Yeah, and this can be really obvious if you were to wear a CGM, let's say, because you can maybe get your hands on one, you wear a glucose sensor, and you do a very vigorous workout, like a high intensity interval workout, you'll see the glucose will go up. And we've put sensors on some of the top cyclists in the world who don't have diabetes, and we see the same thing. So it's a phenomenon that we think is linked to adrenaline. When you have this fight or flight response, adrenaline goes up, and that really just squeezes glucose out of the liver. It causes a rapid rate of glycogen breakdown in the liver. And adrenaline also limits a little bit the glucose uptake into the contracting muscle. So sugar goes up. It's often quite transitory in someone who doesn't have diabetes. It'll pop up for, 15 minutes or 20 minutes, and then your body will secrete enough insulin to bring it back in check. And we see this, of course, in diabetes too.
Yes. So you're saying in the person with type 1, they need to make sure they take. So again, I guess I'm often sort of back thinking about people having to inject insulin. So obviously, so after high intensity exercise, if your glucose goes up, you would need to inject some more insulin to bring it down, or you'll say
sometimes. Yeah. Yes. That is debated at the moment, because although the sugar goes up and you'd think you need a bit of insulin, if you could get the insulin to act and then disappear, then I would say, yes, go for it. You inject a bit of insulin. But what we've seen is that if that exercise is later in the day and someone does an insulin correction for their high blood sugar, then they get a hypoglycemic event later on, because unfortunately the insulin that we inject has a half-life of about 2-3 hours.
Okay.
So unfortunately, it's not really a rapid on and off insulin like you have, secreted right into the portal vein, gets into the bloodstream, and your insulin half-life is a few minutes. But when we inject it into our subcutaneous tissue, the half-life is about 3 hours. So it's another frustration that we have about managing high blood sugars with sport.
That is the absolute worst timing, because you would know the studies we do when we look at how exercise increases insulin sensitivity. We usually look 3 or 4 hours after, and the insulin sensitivity is massively up in the muscles that have contracted. So at the same time, you've got your elevated insulin.
At the same time, you've got that insulin that's too high. So I've learned so much about the normal physiology, and then tried to wrap my head around how we can even try to come close to that in diabetes, and it's really hard. The one story I heard about Gary Hall Jr., who is an Olympian swimmer with type 1 diabetes, 10 Olympic gold medals. His blood sugar went from a normal range to something like 400 milligrams per deciliter, over 25, 30 millimoles, in a sprint that lasted 15 seconds. It's incredible how the blood sugar pushed up on him. He was still able to get that gold medal, but then it was a bit of a recovery process to get his sugar back down.
Actually, just what do you think about, I've thought about this, but I haven't really looked into it enough. I've sort of wondered, why does the glucose increase so much after like a sprint type exercise? And I've sort of assumed it might be to do with glycogen resynthesis. If you've got elevated glucose, elevated insulin, then, the idea is, we were not actually evolutionary developed to do a 50-meter sprint like in the pool.
Yeah.
There's more to get away from a tiger or something, right? To run up a tree. Right. And then I guess while you're up there, you want to resynthesize some glycogen so you can go again. Is that what is your thinking?
I think that sounds like a reasonable hypothesis. I also wonder, why the heck would we design a body that pushes glucose up, to 300 milligrams per deciliter during a sprint? Like, what would be the value of that? The muscle's got tons of energy. It doesn't need the blood sugar to go up. But I think it's just this byproduct of sympathetic activity. Like, we need that sympathetic tone to drive glycogenolysis in muscle. But it's also this side effect on the liver, which is problematic, that I don't see an upside for, really. But maybe that hyperglycemia will help restore the glycogen that was used. That's a great idea. Great theory.
Yeah, because the 30-second sprint, I remember the classic, I think it was Hermanson, classic I'd put up in my lectures and things. A 30-second sprint, you could use half your muscle glycogen in that 30 seconds. When actually during a prolonged exercise, it takes a long time. So, all right, so that's the high intensity. So then you've got the whole mix about what's going to happen, over the next, obviously that evening is really important, right? So the concern about having a hypo after exercise. So I want to tease that out a little bit. If it's prolonged exercise, obviously it depends how prolonged, how intense it was, versus a sprint. Are you more or less likely to have a hypo that evening?
These are great questions. And I don't think we fully know all the answers yet, because it's difficult to do an insulin clamp, let's say, which would be our gold standard for insulin sensitivity. It's hard to do it for so long, like overnight. Who's going to want to volunteer to do exercise in a lab and then be on a glucose clamp for 12 or 24 hours? But we can look at the CGM tracings, and we can look at the epidemiological data, and it looks like the hypo risk is very high the first 12 hours after any intense exercise bout. And it could be a prolonged endurance event where there's glycogen depletion, or it could be a high intensity interval training session where there's quite a bit of glycogen depletion. I think it's linked to glycogen restoration, but I can't fully be confident of that. In fact, I was just at a great lecture by Dr. Carty from Michigan, and trying to understand what's causing this insulin sensitivity after exercise. Is it glycogen? Is it something else? I think there's still more to be learned. But in type 1, you're at risk for at least 12 hours after the end of exercise. So what that means is that if you do late day exercise and you have type 1, you're in trouble overnight when you're sleeping. And that's scary because you don't have the symptoms, you don't wake up, you don't feel them, you're not paying attention. You might even sleep through alarms like people do. So exercise at bedtime is a risk, and we do recommend extreme caution and vigilance if there is exercise around bedtime. Exercise early in the day when there's a bit more insulin resistance and at least you're awake and alert enough, you might be able to sense that glucose dropping in recovery. So I think the exercise time of day is going to be critical for us to think about for patients exercising with type 1.
Okay.
You know, I play basketball at night. I love it. That's when we play, but I have to be really careful, really be vigilant. I have to lower my insulin delivery overnight after I have to have a snack at bedtime. So there's all these things that I need to kind of think about.
Okay. So that's true. It's not like you've, part of me thinks, okay, you've got the continuous glucose monitoring, you've got your insulin pump, you'll be fine. But it's not true because you're not actually adding, you don't have a system that's adding glucose if you have a hypo, do you?
Right, exactly. And some researchers have thought about adding glucagon to the pump. And that is some work that we've done in our lab, and others are doing it in the US.
So just get back about glucagon. So glucagon stimulates the glucose output. Yeah.
Right. So glucagon is the hormone that's anti-insulin, in essence, on the liver. When glucagon goes up, the liver will cause glycogen breakdown and maybe even gluconeogenesis. So if there are some points of the day when your insulin's too high, you could easily counter that if the pump gave you a little bit of glucagon. It would offset that. And so we've done some studies showing that technically is very, very helpful for exercise.
Wow.
But it's another hormone. There's going to be more cost, maybe a second pump. So I don't know whether it's going to be the answer in the next little while or not, but it's interesting to me that we've now learned that glucagon is also dysregulated in type 1. Unfortunately, when someone who's been living with type 1 diabetes for 4 or 5 years, they don't produce glucagon when their blood sugar drops. And so it's like a second hormone that we need to think about, maybe dysregulated in type 1.
Oh, that is really bad. To be honest, I didn't know that.
Very bad.
Oh, because that's the whole point. I was going to say, well, I was thinking, the glucagon would play some sort of role in counter-regulating this stuff. But
yes. And it's been shown that after about 4 or 5 years, people living with type 1, for unclear reasons, are losing their glucagon counter-regulation. Okay. During exercise, during low blood sugar. The glucagon is kind of flat throughout the day and maybe even a little bit too high before meals, and certainly far, far too unresponsive to low blood sugar.
Okay. So it's glucagon release. It's not like, do they get some sort of glucagon resistance or something, or is it just?
No, that's a great question. Studies in animal models and in humans show that the body makes glucagon. It responds to exogenous glucagon, but there's a break on the release of endogenous glucagon at the level of the pancreatic alpha cell. And some of the work that we're doing in our lab is looking at what's that mechanism of action, and can we restore that with yet another therapy, which is related to somatostatin, but I don't want to talk too much about that because it gets very complex.
Okay. So you mentioned glucagon there during exercise would be helpful, but naturally, if we're talking about hypos overnight, that could be life-saving, right? If you could have some glucagon release.
Yes, and some biotech companies are thinking about that. There's now nasal glucagon that a parent could give to a child even if they've lost consciousness. You could do a small injection of ready-to-use glucagon under the skin, and also they've made insulin pumps that will automatically infuse glucagon when that CGM says that individual has a low blood sugar or is trending towards a low blood sugar. So glucagon is really is taking on a life of its own as far as a potential therapy for type 1 diabetes.
Okay. So with the hypo again, because I just think a lot about, obviously it's dangerous, to your life potentially, but also just the fact that it's so hard to get people, that's the thing. I've been studying how does exercise affect metabolism and whatever, but you'll go for grants and they'll say, well, it's all very well learning all this, but we can't get people to exercise, so it's always in my mind that we've got to actually get people to exercise. So what is the data on that? Like because people are worried about having hypos that have type 1. Do they actually exercise less than the general population, which is already pretty bad?
Yeah, that's a good question. The The large scale studies, the epidemiological studies suggest that the exercise patterns are less in people with type 1. Even though they should be more incentivized to exercise for all the health benefits, they are exercising less. But that's a very general statement. I've met tons of people who are very physically active with type 1. So I think some people are afraid to do it, but there's a lot of us who aren't, and we'll do whatever we can to, to do it as safely as we possibly can. But in general, it seems to be a major barrier. And I think that's why obesity rates are up in type 1 diabetes, cardiovascular rates are up, even some forms of cancer are up in type 1. This used to be a disease associated with thinness, and now it's a disease associated with being overweight, more overweight than the average population and more sedentary than the average population. In fact, it's starting to morph into double diabetes for some people. What I mean by that is that you're getting some characteristics of living with type 2. And this was unheard of,
because they leave,
50 years ago.
Losing their insulin losing their insulin sensitivity, becoming insulin resistant, right? Wow.
Yeah, and becoming centrally obese and excess adiposity and insulin resistant. So this double diabetes is really quite concerning, even in pediatric populations.
Wow, okay. So that's why yes, you said they actually need to exercise more than the average person because they've got increased risks. Actually, I wanted to just talk about that. It's in my own mind, sometimes I think, okay, so if you're on insulin, and things are pretty, I know we already talked about how they have higher, or you have higher insulin levels to maintain your normal sort of function. Is it correct therefore, if they do have their insulin and their glucose pretty much under control, are they able to, are they actually at the same risk level as others for heart disease and things? Or is it doesn't matter how perfectly you have your glucose control, they still at a greater risk? And if so, how much greater?
Yeah, it's an excellent question. And when I was diagnosed, people kind of said, well, it probably makes a difference, but we don't know how much of a difference it really makes if you keep your blood sugar in control, in a tight range. But we now know the evidence is overwhelming that tight glycemic control prevents cardiovascular disease, kidney failure, retinopathy, nerve damage, and a whole bunch of other things, including maybe early senile dementia and some forms of cancer, and it linked specifically to poor control in type 1. So it's something we really have to strive for. Almost normal glycemic control will give you a near normal life expectancy. And I think that's something we now know definitively that we didn't know when I was diagnosed.
Wow, great. Okay.
But that is easy to say, but really hard to do.
Okay.
In fact, if you look at the data from what's called the T1 Exchange, which is a large database of type 1s in the US, control has gotten worse in the last 15 years for type 1. And we thought it was going to get better. And it's still not too clear why control is getting worse. If you look at average glucose, it's higher. Percent time above the target range is higher. And it's still not too clear why. But control is not getting better.
Wow. This has to be the people that don't have pumps, I guess. I mean, are they people that have pumps?
That's true. That's true. If they have pumps, if the evidence says if you have pumps and CGM, it is lowering this exposure to high blood sugar, which is accumulating all these reactive oxygen species and damage to all our cells, and that may be the cause of our premature aging. If you are on a pump and CGM, you will lower these risks. But if you lower your sugars too much and you get hypoglycemia, that'll kill you in one night. So it's a very delicate balance.
So you're saying when you look at type 1 diabetes in the US, their control is worse. Is that taking into account everyone, so even the 50% or whatever it is that have pumps? Does that mean that the others are just terrible? Is it?
Yes. Yes. The ones who are on pumps and CGM are doing the best. But to be honest, their control is really not as good as we'd hoped it would be because of that evolution of technology. And I think it has to do with lifestyle. I don't think, I don't have proof of this, but I think the liberalization of carbohydrate feeding, simple foods, fast foods, overconsumption of energy dense foods, which didn't really exist for type 1 diabetes 50 years ago. You were told to be on this diabetic diet that didn't include this. But this liberalization of food and this relative inactivity has made metabolic control worse. But to you, that makes sense, right? Like poor metabolic control linked to poor diet and inactivity, like that makes sense to you as a physiologist.
Yeah.
For some reason, it's not made sense to many endocrinologists or patients living with type 1, which is a shame.
Okay, all right. So that's sort of back to the thing we touched on earlier, that that the endocrinologists don't necessarily understand exercise, I guess, and they don't necessarily understand nutrition, and well, I guess you'd like
or metabolism. They admittedly they don't. Yeah, they don't. All they know is if your blood sugar is too high, prescribe more insulin. But prescribing insulin doesn't fix insulin resistance or obesity. In fact, there's evidence emerging that it makes it worse.
Okay.
So I think we have this double diabetes that's developing, which in part is related to lifestyle. And I think that the technology is not fixing that for us, unfortunately.
So just to clarify, we sort of touched on it before, but the double diabetes there is obviously the person with type 1 has not got the insulin release that they need to have from their pancreas, and on top of other bits and pieces. And then the person with type 2 has the problem where they depending on how advanced they are, but they produce the insulin. And early on, they produce more than normal because their body doesn't respond to the insulin because the body is insulin resistant. So when you say double diabetes, you've got the people with type 1 don't have enough insulin, and then they're also insulin resistant. So it just becomes, if they're not, staying lean and exercising and things.
And then physicians will just prescribe more exogenous insulin. So they might be on 150, 200 units of exogenous insulin a day, but it's not really keeping their blood sugar in control because they're insulin resistant. The foods they're eating aren't helping their metabolism, and they're maybe not exercising.
Yeah.
But then if you look at this other group that I work with, these are lean, elite level athletes or college level athletes. They're on 20 units of exogenous insulin a day. They're super insulin sensitive. They're lean. They're fit. They're likely going to live longer. So this concept of double diabetes is starting to ring clear to me that we've got a real problem if we have obesity in type 1.
Yeah, I mean, let's talk some more about that, I guess. So, there's been obviously a bit of doom and gloom. We're talking about double diabetes and things, but let's focus more and sort of expand more on how well people can do with type 1 diabetes. So you've got, I think it's called Team Type 1, right? The professional cycling team.
Yes.
So these guys would be really insulin sensitive, just like people that don't have diabetes. So then they don't actually even need as much insulin. So they don't have to inject, or the insulin pump doesn't have to inject. So I don't know, maybe you've obviously done a lot of work with these people. Maybe just expand on that, on how well people can do. I mean, you look lean and healthy and a nice glow and all that, if people exercise, eat well,
And what I was just astounded by in working with Team Novo Nordisk is that they are actually able to consume 600 grams of carbohydrate in a day in a stage race. Like they're doing a 5-day stage race, and we were monitoring what they were eating. We're monitoring every unit of insulin they took. They could get away with consuming 600 grams of carbohydrate in a stage race, and they were taking 5 or 6 units of insulin a day. Like that just shows me how exercise makes them super insulin sensitive. If you were to take someone who wasn't on that team and tell them to eat 600 grams of carbohydrate, then take as much insulin as they need to keep their blood sugar reasonably under control, it could be like 150 units. Like it's just a huge difference. So I think that we've learned so much from these types of athletes who are very insulin sensitive. Their machinery, their muscle metabolism, their glucose oxidation rate is so high, and much of their glucose disposal is through contraction-mediated glucose transport, which you're an expert in. And reading your papers, I realized that is the secret really for type 1 diabetes. Use that pathway for glucose metabolism. Don't fuss with the insulin signaling pathway that you have to hit with repeated doses of insulin. So I think it's fascinating to think about these other metabolic pathways. That's why your funding needs, that's why your grants need to be funded, because it makes a difference on how we learn for clinical populations.
Well, absolutely. So when you're talking about that 600 grams or whatever, a lot of that, most of that, they would probably be using during the actual exercise. So while you're exercising, you're taking up glucose. If you ingest carbohydrates, you'll take up more glucose, because you increase your glucose concentration. You get a greater glucose, concentration dependent glucose uptake. The insulin will increase it if, well, this is the other thing. I just want to step back a little bit. I guess we probably should have almost said this earlier. When you're exercising, so if you don't have type 1, for example, when you're exercising, your insulin decreases, right? So people go, well, hang on a minute, what's going on there? And it's because, as you said, you've got your contraction-stimulated glucose uptake. So the insulin actually decreases. The body takes up the glucose by the contractile process. And again, things are complicated. We're still trying to work out what the mechanisms are, but it's clear you don't need insulin. Eric Richter showed that years ago.
That's right.
So during the exercise, you don't, as you said, let's focus on this non-insulin dependent pathway and interestingly, even people with type 2 diabetes, they have totally normal glucose uptake. So us and others have shown this. During exercise, their glucose uptake's normal. And then you start to think about after exercise. So that's when you need, your muscle's going to be more sensitive to insulin. And then if you have more insulin, you have more glucose uptake. But anyway, the bottom line is these athletes are basically behaving as you'd expect a person without type 1 diabetes. They're taking up glucose during exercise because of the contraction. And then they're very insulin sensitive afterwards. So they're sucking up the glucose without necessarily having to think about the insulin.
Exactly. And I think that the normal physiology and the somewhat abnormal physiology is so interesting to learn about. Much of that normal physiology is perfectly mimicked in that athlete with type 1 diabetes. It's just they can't fine tune the glucose quite as well as that non-diabetic athlete. Yes. It can sometimes be a bit too low and sometimes a bit too high, and we know that affects their performance. So these athletes have done just an exceptional job, over the last several years, being in competitive races and doing the best they can with their sugars. And there's lots of times when it's too high or too low, but they've got a team supporting them, dietitians, nutritionists, sports medicine doctors who are very, very well educated in this metabolism field and also diabetes and endocrinology. So I think they're well supported, and they need to be, because it's really complex. It's very difficult to manage.
Okay.
Like we're talking about managing just 5 or 15 grams of glucose in circulation if you look at the glucose in the bloodstream and interstitial space. So it's a wonder they can even do it, quite frankly, but they can.
Yeah, it's amazing. So we know that it can be done, but again, we need people to do it. Yeah. And you're saying it's actually going backwards. So as we're getting better technologies and things that should be improving it, we've got the human condition, the obesogenic environment, the lack of activity that's actually taking things the other way.
And maybe in type 1, you need something more than just a new device or a new tool. You need a bit more education, a bit more management, a bit more support. This is a disease that you live with 24/7, but you don't get a lot of support. You might see a doctor twice a year who maybe knows nothing about exercise management. You're lucky if you get to see a dietitian or a nurse for 15 or 20 minutes. There's not really enough support or education the way it's designed right now. I think we need to improve on that market.
Well, it's a medical model, isn't it? The way things are, it's like a medical model. My wife used to work at I won't say where it was, but they'd always say that the 3 pillars of diabetes, you've got the pharmaceuticals, so the drugs, you've got the nutrition, you've got the exercise, but they didn't actually have an exercise person employed at that time. My wife actually had nutrition and exercise background, so she, you can do both, So
and that's why I'm as busy as heck, because there's not a lot of people who know what I know, who's lived it for most of their life, and who's willing to help every person I meet who has type 1 to try to do better. But I still make mistakes, so I can't claim to be perfect with my metabolism.
Hey, just one thing again. at one stage that there was talk about how obviously the elevated glucose has damaging effects, as you said, microvascular problems and whatever.
Yeah. Yeah.
And then you've got the elevated insulin. So you're saying with someone
Yeah.
type 1 has elevated insulin, what's the evidence on that? Does the elevated insulin itself cause problems to
Yeah, there's a hot debate. Even at the American Diabetes Association meeting this year, there was a hot debate by a Canadian scientist, Dr. Jim Johnson, who thinks that hyperinsulinemia begets more insulin resistance and deteriorates metabolic control and maybe even predisposes to cancer. But then there's other researchers at Harvard who say, well, hold on a second. I don't think hyperinsulinemia is the cause of diabetes. It's the result of type 2 diabetes. So it's heavily debated. But I am leaning on the side of Dr. Johnson lately, although I never believed his theory 10 years ago. I think hyperinsulinemia is a problem. I think it makes the situation worse, particularly when a physician prescribes more insulin. Like if you think about endocrinology, any hormone that you give in excess will cause a downregulation of receptor signaling. Like that's just basic physiology, right?
Mm-hmm.
So why don't we believe that for insulin? So I think I'm starting to think that hyperinsulinemia may be promoting disease rather than the result of the disease.
Okay. Wow. All right. So then that brings us sort of full circle again. So even if you've got your glucose control perfect, which is
the high bar,
perfect as you can, you're still going to have that problem that you've got high circulating peripheral insulin.
Yeah, particularly if you're inactive and you just infuse more and more insulin to get your sugars down.
Yeah.
So if you look at the longevity studies that people are like, who is it that's living 50 or 60 years with this disease? They tend to say that they're physically active. So I wish we could prove that exercise makes you live longer, but it's hard to prove in type 1. I think the evidence is accumulating, but we don't have definitive proof yet. I'd like to say that exercise does all these beneficial things, including improving insulin sensitivity, which makes you live longer. But I can't say that with 100% faith yet.
Okay, so is there not enough epidemiological evidence, or?
Well, they'll say, well, it's just good glucose control. They're living longer because they have good glucose control. So it'd be fun to do an experiment. Maybe you'd have to do it in animals where good glucose control comes with more insulin versus good glucose control with more exercise. But then they're going to say, well, exercise has these other beneficial effects. And how do you know it's the hyperinsulinemia? So it's really a tough question. Maybe you can help me wrap my brain around proving it, but it's hard to do.
Wow. Okay. Okay. So one thing I wanted to finish up on is, what are you doing nowadays? It's more like, what am I doing nowadays since I took my package? You're working hard.
I wish I could be in your boat for a while and not worry about, teaching and grants and manuscripts. Well, I'm sure you are worrying about some of those things, but what I'm doing right now, is I'm wrapping up this very large study in the US where we had 550 type 1s exercising at home during COVID, which was a lucky coincidence. We had no problem enrolling subjects and using exercise wearables to quantify their activity levels using heart rate monitors and accelerometers, and then looking at their glucose management with CGM, and of course getting insulin data from their insulin pump downloads or from what are called connected pens. You can have a digital pen that records your insulin injections, and then that information can go into the cloud. The overarching goal is to figure out, like, why is glucose variability so large in type 1 diabetes? Like, we don't all respond the same, and what's behind this patient variability and within patient variability, so that we can just flatten out that glucose a bit more when people are doing exercise. And that's a big project that's funded by the Helmsley Trust in the US. And we are about to submit our first paper on that. We've submitted and presented at the American Diabetes Association just last week about how exercise is helping keep their glucose in range and what are some of the key variables that are causing glucose variability, which is kind of exciting for me.
I'm glad you brought that up, because it's one thing I've thought about here and there, and we touched on it before we did this talk. How whether you're nervous or not will affect glucose. So the thing, someone mentioned to me at one stage, there's a person I know with type 1 diabetes who is pretty much a professional athlete. She said she could do the same like 1 hour time trial in training, the same speed, same watts, same everything. But if she does that time trial in a race, the glucose is just all over the place because of the adrenaline, I guess, again. So what are some of those sort of variables?
That's a key one. We took a bunch of hockey players and we filmed them playing a game, and we measured their heart rate, and we duplicated the hockey as best we could in the lab, but we couldn't duplicate the competition stress, and the glucose response was different. And that is fascinating. So something about noradrenaline or cortisol, or who knows what it is, you get a different response under competition. People see their blood sugar goes up during a math exam when they're in school, or they get in a fight with their girlfriend or boyfriend or wife or husband. Like, we see it, but we don't fully know the mechanisms, which is fascinating.
It makes sense.
But there are other things, like menstrual cycle seems to affect it, whether you're male or female, your age. Is it the daytime you're doing exercise? Is it the evening? Like, there's probably around 40 variables that we've identified that are feeding in to whether your blood sugar is staying flat, dropping at this much of a rate, or dropping at this much rate, or rising. 40 factors.
Wow.
And so it's very challenging.
Another weird one is if you're doing something you're not used to. So if you're like you normally run and then you cycle, or even if you're painting or gardening and you don't normally do that, these things that you wouldn't expect to have much effect can have a decent effect, right?
Yeah, we think so. We think that if it's a new activity, you might have more hypoglycemia risk. I don't know if you've heard that from any of your friends with type 1, but we've heard it repeatedly, and we don't know what it is. Is it the muscles are using a different fuel source, or is the brain somehow activating the sympathetic nervous system in a different way so that the liver's, we don't know, but it's fascinating.
Wow. So it's just so complicated. And I feel bad for you, because it was hard enough for me trying to, I was a glucose metabolism exercise researcher, so my main thing. It's hard enough to keep on top of all the literature in that area, but then you've got to do it with people with type 1. But also, I tended to focus on glucose uptake during exercise. Later on, I started looking at insulin sensitivity after exercise. You've got to have that whole thing.
I have to read all of your papers, and like I have to read about nitric oxide and AMPK and all the stuff you've published on, and have to how does this work in diabetes, which is it's exceedingly complex. I do a lot of reading.
It's really interesting. Okay, well, thank you. Is there anything else you think we got through a fair bit there? Is there anything?
Yeah, there's everything I want to talk about, and then some. I wish I had more solutions than identifying problems, but it's been a real pleasure, Glenn, and an honor to get a chance to sit and chat with you about this.
Well, I've read a lot of your stuff as well, so thank you very much. Actually, one thing I tended to forget the first couple of podcasts is maybe have some sort of summary, some sort of bottom line, bringing it together. How would we summarize all this? That there's great potential. Well, why don't you summarize? I was going to say exercise.
Yeah, I think in summary, it's one of the most, in addition to taking insulin to stay alive, exercise is one of the most important things we can do to allow us to live longer and healthier. But we have to put a lot more vigilance on choosing our exercise a little bit more carefully, choosing when we do it and how we administer insulin and carbohydrates to keep our glucose in control as best we can. There's a lot that needs to be done. And I think that we need better resources to support these patients who are trying to do the best they can, but are still struggling. We're all still struggling. But it's been a career that's maybe half over for me so far, and I'm going to continue to work for another half to make sure it does get better for all of us.
Right. And it sounds like as you touched on, education is just critical.
Yeah, you kind of need a master's or a PhD in exercise physiology if you really want to tackle this smartly with type 1.
All right. Well, great. Thank you for your time, and great to chat, and I'll see you next time.
See you next time, Glenn. Thanks so much.
See ya. Bye.